Let's see.
Hello, Tim. I can hear you.
Wonderful. So thank you all very much. Those were, Elizabeth, thank you for the co-chairing. And those were two really terrific presentations by Nyaradzo covering really an extraordinary overview of the very exciting HIV prevention arena we're in now. And my colleague, Margaret, presenting really a masterful presentation of the landmark ECHO study, which has really moved us forward in this arena. Let me start off with one question that immediately comes to mind, and it really is that the issue of HIV prevention for women at high risk, particularly in Africa, and women that need contraception services. And Margaret, you touched on a couple of these issues of how to integrate STI HIV services with contraception. And one of the questions that came our viewer is, are there now activities to have combined products that both provide HIV pre-exposure prophylaxis and contraception? And Nyaradzo, why don't you start with that one?
Perfect. Thank you very much, Tim. Yes, allow me to really say that, as everyone knows, these presentations were pre-recorded. So really today I'm excited. Today is World AIDS Day. And just yesterday on the 30th of November, we heard about the pre-qualification of the dapivirine ring by WHO. So that's really an update that I would like to share with our viewers, with our conference participants, that since I made this presentation, maybe over 10 days ago, there have been so many significant advances in terms of the approval of the dapivirine ring. So time permitting, we'll discuss about that. But let me get back to the question that you asked, Tim, regarding combining pre-exposure prophylaxis and STI prevention. So it is the hope, as Margaret talked about, women in sub-Saharan Africa will remain at high risk for HIV and other STIs. So the ultimate goal really is to provide women with a product, depending on where they are in their season or where they are in their life, whether they just want HIV prevention, whether they just want even contraception, do they want STI prevention, HIV prevention, and STI prevention, pregnancy, contraception, all the works. So yes, there are plans already in terms of multi-purpose prevention technologies. There are various interventions that are being researched on. For example, there's a ring which is already looking into HIV prevention as well as contraception. And also there are other products, even the ring, which will be looking to provide HIV prevention, STI prevention, as well as contraception. So it is about integration so that we have women's services, SRH services under one roof for women, so that we integrate all their needs in one product. So yes, that is the ultimate goal, and we owe it to the women, especially here in sub-Saharan Africa. We don't want to have any unintended pregnancies. We don't want to have any new STI infections. We do not want to have any new HIV infections. So it is our ultimate goal in terms of product development. And besides the ring, I should have mentioned, I did show the multi-purpose prevention technology, the intrauterine system that Conrad is working on, and there are many other products. Yeah.
Over. Well, thank you. Thank you, Nyaradzo. It is really an extraordinarily exciting time in HIV prevention. As you described very clearly, we now have new oral agents. We have TAF and islatravir coming down, the pivirine ring, which is the first intravaginal system, and long-acting PrEP. Every 2-month cabotegravir injections for PrEP that could be coordinated in some fashion with injectable DMPA for contraception. Mm-hmm. So it is, in the next couple of years, it'll be even more exciting as we roll these out. Let me ask a question for Margaret. Margaret, once again, thank you for the wonderful overview of the landmark ECHO study. which gave us tremendous information about access to contraceptive services for women at high risk for HIV infection. And it's been more than a year now since WHO revised their guidance in August of 2019, indicating that all of the contraceptive methods you talked about, DMPA by injection, a copper intrauterine device, and a levonorgestrel implant, may all be used by women at high risk for HIV infection. And as the investigators from ECHO said, the greatest fear was that after finding that good news about contraception, there was unfortunately the very high HIV rates that you showed, 3.8% overall, and even higher among young women. So the concern was that the world shouldn't return to business as usual. You described very clearly programmatic activities that could happen to integrate HIV prevention with family planning. But now it's been more than a year since ECHO, but of course we've lived through COVID for the last 11 months. Can you describe the impact of the COVID epidemic on HIV prevention and family planning services in your setting in Zambia?
Thank you very much, Tim, for that question and the pre-discussion to that. And just to let everybody know, I survived COVID, and so I know what impact it has, first of all, on the person. And so just now to talk about what it can have on services. So in Zambia, the reproductive and sexual health services were impacted because, one, the clinics were by default closed. So the clinic that provided services for everybody were closed, whereas with the woman-centered services. So that if a woman comes to the clinic, they found it hard, first of all, to get access. And two, access was further denied because we required our people to come with PPE, which maybe they didn't have access to. So if you didn't have your mask, you can't come in. So first of all, on the personal level, access was low in that regard. Then two, our members of staff were also not, had to prevent infection also. And the availability of PPE was not all the time available, so that people were providing the service were afraid to be in the clinic, or were afraid to meet people because you're not being protected yourself. In terms of the supply chains, those were affected because also people working in the offices within the Ministry of Health would not be in the office at all times. So it was from the person right up to systems. COVID affected particularly women's services. That's what I can say about how we face what is happening with COVID.
Great. All right, well, thank you. Hopefully we will be able to weather the challenges from COVID to take on these important prevention issues and contraception. Margaret, there were a couple of questions that came in from one of the participants. One was, could you tell us a bit about the male partners in ECHO? Were they part of the study or not? And also tell us about the HIV prevention services that were provided for the women in the ECHO study.
Okay, so ECHO it recruited women who were HIV negative and seeking contraception. Much as we involved the male partners, these were not our participants. So we do not have data on the male participants as collected by a research study. And the second question was the HIV prevention strategies that were given to women. We gave a comprehensive prevention package, which included condom use, STI screening and prevention, contact tracing and treatment. So the whole package. And when PrEP became available, we also provided that. So our women were not just offered contraception, but also the full package of prevention of HIV and STIs.
Well, thank you, Margaret. And actually, the time course of the ECHO study points out how incredibly dynamic the HIV prevention world has been, because the study started in late 2015, where PrEP was not registered for use in the African countries where the study was done. during the next 3 years, PrEP did become available either through demonstration projects, and PrEP was indeed offered to the ECHO participants as the study proceeded. So fantastic. Nyaradzo, back to you. So you gave us this tremendous overview of use of antiretrovirals for prevention by oral pills, by intravaginal rings, and by injection. And then you really intrigued us at the end by talking about something quite different, monoclonal antibodies by infusion, in both the African setting for women and globally for MSM. And then you talked a bit about the product used, the VRC01 antibody. Now, we haven't seen the results. They haven't yet been published. You indicated that the product would not be registered. What's next coming down the road for monoclonal antibodies?
Mm-hmm. So thank you very much for that question. Very important. And yes, when we said I'm one of the protocol co-chairs for the AMP studies, and I acknowledge all the other team members. So when we set up to do this study, our mandate, it was never to register VRC01 to be a product on the market. Rather, the two studies were proof of concept studies, which we set up to prove whether monoclonal antibodies, the monoclonal antibody VRC01, whether if it is infused intravenously, can it prevent HIV? So these were proof of concept studies. That's what I need to ensure that our listeners understand. And now that we've completed the studies, the results will be released shortly, and the results really will allow us to work on other monoclonal antibodies better in terms of potency, better in terms of having a wider breadth of HIV prevention. So already work is underway in terms of studies looking at other more potent monoclonal antibodies with wider breadth. So the purpose of the AMP studies was really to give evidence in terms of monoclonal antibodies for HIV prevention, and also to expedite the HIV vaccine research agenda. Yeah.
Great. So very exciting to have a new tool in the toolbox, monoclonal antibodies for HIV prevention. And of course, now we're seeing in the world of COVID that monoclonal antibodies are being used both for treatment and for prevention. And so really exciting years ahead of us, I think, on the use of passive antibodies for both treatment and prevention. Let me go back to Margaret. There's a question for you. It's related to the STIs. So you pointed out the high rates of STI risk in the women in ECHO. 18% had chlamydia at enrollment in the study. 5% had gonorrhea, and similar rates after being in a clinical trial where women are getting condoms provided, they're getting syndromic management, they're getting services. Yet they had high rates at the end of more than an 18-month follow-up in this study. So the question gets to syndromic treatment. Where does syndromic treatment fit in? You mentioned we want to move beyond that. And the question from the reader was, how about for men and women in terms of management of STIs?
So syndromic treatment has been going on for quite a while now, and it helps in low research settings where we do not have a specific test to test what are we dealing with when somebody presents with an STI. And this is the approach that we used in ECHO. And what we have seen is that if we are getting the same rates at the beginning and at the end, it's like there's nothing happening in the box in the middle. And so it speaks to the need to be more innovative in the way we look at these STIs in terms of making a diagnosis and trying to treat specific disease, as well as looking at, is there another way we can approach the prevention? So not just focusing on the woman, but also looking at her sexual partners, so that we are more creative, more innovative in the way we approach the male component of this cycle. Because we might just be looking at one partner, maybe there are more partners. We may be looking at giving her a slip to go and for the partner, but maybe that is not reaching home. So are there other ways that we can engage, not just the man, maybe the whole community, to be able to make this connection more effective? So more diagnostics and better ways of looking at contact testing.
Yeah. And again, that's stepping back a bit and thinking about HIV technologies. There's been such an explosion of diagnostics related to COVID, of new nucleic acid tests used for COVID diagnostics. Perhaps we could actually expand the point of care rapid STI diagnostics that could be coming down the road. So we'd have inexpensive, rapid point of care. So we could really move STI management in Africa, especially for women, away from syndromic to really having high quality specific diagnostics. So again, an exciting time in diagnostics as well as treatment. So Elizabeth, as co-chair, any other questions for you?
I think our time is done, and it's actually tea time, Tim. So I think you announce the tea break because we've run out of time. There's so many interesting questions, but we can't get to all of them. So I think you just need to announce the tea break. Really thank Margaret and Nyaradzo for the excellent presentations. And then people will be back after break.
Thank you so much, Nyaradzo, Margaret. You were terrific. Thank you so much.
Thank you.